for us as physical therapists, I think one of the biggest roles we have with nursing is that we're trying to make sure that there is an understanding of any safety issues, or making sure that we can teach the nursing staff how to work with these patients so we can prevent any type of injuries or anything like that when it comes to them working with the patients, because we know most of the time y'all are the ones working with them, allowing us to just make sure we can see kind of how these patients are doing over time, if there are any changes that does occur, either with mobilizing them, or even if it just comes to like how they are doing, whether it be neurologically or physiologically. So one of the incidences that we had was, we had a patient that had come in, she had previous strokes in the past, but the husband had actually told us that this was not at her baseline. So as we started doing our testing and stuff, we noticed that there was right-sided weakness and all these other things. Luckily, we obviously, with the great nursing staff that we had, we were able to go talk to them, come to find out she was actually having an active stroke at the time. So we were able to like shift her over to neuro and kind of get her onto the next stage when it came to whatever her care was. So yes, I do believe there's a very strong correlation with why PT and nursing need to work together so well. One of the biggest things for us is like in wound care is making sure the patients are pre-medded. We usually call up and just ask, hey, can you please get the patients pre-medded before we come and see them? The other thing is, in terms of mobility, if there are any changes, yes, we look at the charts every morning, make sure everything's okay. But to be honest, y'all know more up front than even before people can get into the charts. So it's always nice to talk to y'all beforehand. If there's any changes, whether it maybe be from the MRI, from the CT, if there's any change in cognition, things like that, y'all play a huge role for us, making even not just for when we're working for safety wise, just making sure that the patient's treated well. Sometimes y'all even tell us like, hey, this patient might do better if you talk to them this way, or if you mention this. Y'all really do help us out with that, so we're very grateful for that. I don't want to call this a misunderstanding. I think it's just a point at which we can improve from here. So what I would say is that most of the time people think that patients have to be seen by PT to get them up. That is true in some cases. That's usually with the higher complexity patients, the ones that probably have a lot of comorbidities, maybe have other things going on, have a ton of other surgeries that have occurred, just a lot going on. But there's some that come in, they're min assist, the contact guard, really no other issues. We've had trouble in the past where like they've been told that, hey, you can't get up unless you're with nursing. Obviously, we know that neuro research kind of shows like progressive mobility, making sure we're getting these people up and moving kind of does help. So the only thing is I urge you that when we have this discussion, it's more so that we're trying to get these patients up and moving as quickly as possible. Obviously, they don't need to be seen by us first to get them up. But if you do truly feel that it is a safety issue for yourself, then by all means, please wait on us to come and check on the patient and make sure they're doing okay. But if you've seen them up and moving already, don't tell them no. Just make sure you're by them at least initially, and then after that we can come and check on them and see if there's anything else that's wrong with them.
Our job is very encompassing. It involves communication and swallowing. So we always work with nurses to help keep the patient safe. And help improve communication and swallowing safety. Our goal is for nurses to feel confident communicating with their patients and feeding the patients, feeling comfortable with the recommendations that we provide to help better care for their patients. Our evaluations are very comprehensive, and there's a lot that go into speech and cognitive evals and swallowing evals. So our recommendations might work for one patient and not work for another patient. So if you can just follow our recommendations that we provide, because it's always for a purpose. Feel free to always ask a speech therapist if you have any questions. We're always happy to help you and every patient. So if there's any questions about communication or swallowing for a patient, just feel free to call us or CareAware. There's 10 speech therapists and we're in every unit, so feel free to reach out. Because I know sometimes we recommend crushing meds that can't be crushed. We just we work with what we have. So just feel free to reach out and ask any questions about swallowing or communication. A lot of nurses forget we do speech, language, and cognitive evals, and also speaking valve evaluations for trach patients and handle laryngectomies. So we have a lot of different hats that we wear in the hospital. So basically anything from the neck up is something that we should probably be involved in. Every stroke patient we would like orders on. We should be at least evaluating all stroke patients. We see all ages, from NICU to pediatric to adults. We're in all units. We work with mostly feeding and swallowing, but also cognitive communication disorders. Thicker is not always better with liquids. So when we recommend thickener, it's for a specific purpose. It doesn't work for all patients. So sometimes thin liquids are better and they're aspirating thickened liquids. It just depends on the patient. Nursing swallow screen is different than our swallow evaluations. The purpose of the nursing swallow screen is to see if a patient needs our services. So if there's ever a question, just put in a speech consult and we can help you figure it out. So,
as an occupational therapist, I look at a patient's ability to take care of themselves. So pretty much in the hospital, it starts with the basics: toileting, grooming, bathing, dressing, all the things they do on an everyday basis. So typically they're up and moving and out of bed doing all those things. So with nursing, it's important to talk about how the patient is doing medically before we go and see a patient. That way we make sure they're appropriate. Also talking with nursing and seeing if the patient has been out of bed or if they've been helping turn or helping bathing themselves, toileting, all that thing, just to make the process smoother when we go and evaluate the patient. We really aim to help nurses in talking with them after our evaluation, and that way we can relay their mobility, how they're able to get up and turn. That way they could use a bedside commode if they can, or walk to the toilet, really minimizing using bedpans when it's not necessary. Also, we could really help reducing the risk of pressure ulcers, things like that, if they're able to get up and move fairly easily, encouraging nursing to do that without therapy there. Positioning them in a way that they're more functional, even in bed, able to help with feeding themselves. I see a lot of times nurses just automatically put the pills in their mouth and help them with the drinks and stuff. Getting the patients to do as much as they can for themselves while they're here in the hospital. That way they get more independent faster. And that's our goal in therapy, and I know nursing can help out in that sense too. As occupational therapists, we see any patients that are weaker. It could be just overall endurance. That way it's affecting their ability to complete their ADLs independently like before. We also see patients with any upper extremity weakness, positioning, sometimes injuries of upper extremities, anything like that. Sometimes PTs get order on a finger that has been amputated or injured, anything like that, and usually that's something that OTs address specifically, and we make positioning devices as well. So any patient that you see that might not be able to do their daily tasks like they were doing before, or upper extremity weakness, or even just overall endurance, those are the kinds of patients that we see and evaluate. And of course, if we don't have orders on, as nurses, being able to advocate for the patient and talking with the team and asking for orders if it's appropriate. Like I said, communicating with nursing about if they've been out of bed, if they have attempted to move a patient, things like that is one of the biggest things that help us do our job. It would be really helpful if nurses could disconnect patients from anything that is not crucial to run at that time, even like feeding tubes, extra lines, prima-fits, things like that are just one step that will help us be able to get a better idea of how the patient's doing. Also, a lot of people wait till therapy comes to see a patient to get them out of bed, But we really encourage all staff to try and mobilize the patient as soon as they can. So starting getting the patient edge of bed, and even if you feel unsafe, then returning them back to bed, but at least attempting, because a lot of people just hold off and think therapy are the only people that are able to get them up. So it's really important to work as a team, getting everybody moving these patients as much as they can while they're here. That will reduce the length of stay, and also, like I said, pressure ulcers, a huge thing, and that way hopefully patients could go home instead of having to go to a facility if they're getting weaker just laying there in bed. Also, we a lot of times as occupational therapists make splints for patients, and we sometimes require the nurses to put them back on. So if you're not comfortable with knowing how to put a splint on or anything like that, just reaching out to the occupational therapist on the floor, and we're more than willing to show you guys and educate you on the use of the splints that we make and we order as well. We rather you put the splints on correctly than put it incorrect where it could cause a breakdown or even rubbing. So it's better just to reach out, and we're more than willing. And that way we can work as a team to position the patient better, get them moving faster, get them helping with all their daily activities while they're even here in the hospital. A common misunderstanding with our role as occupational therapists is that we don't get patients out of bed. So one of the biggest things is when you're completing your daily occupations is you're out of bed and moving. And so that's why we work hand in hand with physical therapy, getting those patients moving quickly, and that way they're able to become more independent. So that's something that a lot of people are like, well, you can just do in bed assessment, things like that. But our goal is to make the patient as independent as they were before, and that's usually getting them up and moving and walking them to the bathroom and in the hallways or whatever it takes to get them back to their level of independence.
Interaction with nurses, as me as a pharmacist, is extremely important. I couldn't do my job without talking to nurses. Obviously, you guys know that nurses is the conduit between the pharmacist and the patient, and also the pharmacist and the doctor, So we require nurses to do our job. Unfortunately, sometimes we don't always have the chance to have a face-to-face interaction with the nurses. The hospital has tried a lot of things to solve that problems. Now we have decentralized pharmacists sitting on the unit, so if you ever have an issue, reach out to your pharmacist or call the pharmacist's main number to figure out how to reach the pharmacy to attend to your needs. Patient safety is a big issue with the hospital. Obviously, my goal and your goal as a nurse is the same. We want to increase patient safety and also have the best possible outcome for our patients. So anywhere where there's a dropping gap in treatment or therapy or in patient care, it affects you and it affects me. It makes us not look like we are a team, So it's very important. The pharmacist, me as a pharmacist, my job, especially because I'm a decentralized pharmacist, is to help you optimize your patient care as far as medications is concerned. We answer your questions if you ever have any questions, or we troubleshoot issues. It could even be issues with the PEG-6 machines or with something on the EMR. We do the best we can to help you with that. I think the biggest thing is patience. As you guys know, your job and our job is stressful, dealing with family, dealing with patients, dealing with physicians. We all have frustrations within our jobs, You need to be patient with you as a pharmacist, and you need to be patient with me as a nurse. And then the biggest thing is communication in patient care. Obviously, we don't have access to patients every single time. You are the one who knows the patient more than we do. So we rely a lot on you to tell us what's going on with the patient. As far as if there's a change in order, if the patient is getting discharged, as an example, we need to kind of know that. If it's something that relates to what we do, as an example, if a patient is on TPN and they are going home and there are orders for TPN, call the pharmacy and let them know that, hey, by the way, this patient might be going home. Check with the physician before you write a TPN, because we don't want to write a TPN order and then we can't use it. That's a cost issue, And then charting, we depend on you to chart appropriately. Believe it or not, we look at the charting that the nurses do. If you chart things incorrectly, and we are looking at that to do our job, we may also do things incorrectly. Drawing labs, we depend on you a lot to draw labs. If you're not able to draw your lab because a patient is off the floor, call the pharmacist. Or if you miss a lab, or just anything to do with drawing labs that we depend on you, call us and let us know. At least we can reschedule it or find other ways around it. Also, alert pharmacist if there are issues in medication delivery. In other words, if you've been waiting for your med that is due at 9 o'clock and it's 12 o'clock and you haven't come back to talk to the pharmacist yet, I think there's a problem with communication there. We shouldn't delay meds for more than an hour, I would say. Come by, call the pharmacist, talk to your pharmacist, and let us know how we can help you get those meds up on time. Okay, I think the biggest problem between nurses and pharmacists, honestly, is communication with medication delivery. I think nurses always feel like their meds are always delayed, and pharmacy feels that we're doing the best we can, and probably we feel like it's not good enough for the nurses. But to be honest with you, I think both nurses and pharmacists have a role to play in making this a lot easier. As an example, let me just focus on medication specifically. Order your meds ahead of time. Don't wait till shift change to order your meds. Don't order everything stat. Only order things that are stat. Because when you order every single thing stat, you're actually causing delay in other meds that should have been stat, that are not, that should have been done stat. When you order something stat, we assume everything is stat, and we just kind of make them in order that the med requests are received. So don't do that. Do not overorder unnecessarily. In other words, if you just go to Dre for vasopressin, simply the fact that the last one took a long time, don't go in and order another bag right away, because obviously the last bag is supposed to run for 12-15 hours. So don't request for a new bag when you just got a bag just within the last 5 minutes. Communicate any change in patient care. In other words, I mentioned the TPN thing earlier. If you know a patient is going up as an example, and they're on TPN, let the pharmacist know, or just other issues related to patient care. And then one big issue we have is when patients transfer from floor to floor and the meds are not being transferred to the appropriate units. That's a big issue. It delays care. It delays patient care. So in other words, transfer the meds to the right unit. And if it's something that can be transferred, let the pharmacist know. In other words, so that the next nurse is not waiting for those medications. And then get trained appropriately in the PICS, with the PICSs, how to work around the PICSs or the Omnicell, which is what we have now. If you're not sure how to use the Omnicell, get your charge nurse or a different nurse to train you appropriately how to use it, because that would really help you as far as making sure your meds are not late, making sure you know where to find things. And then the last thing is look for the meds. Don't just order things randomly. I have some nurses coming on a shift and they request every single med without even looking for it. And I do understand why some of them do it, but it's not appropriate to do that. Look for the meds first, and then if you can't find a request for the meds, or talk to your pharmacist to figure out how to get around getting those meds on time to you. I think one way that we can improve the communication between pharmacists and nurses to some of these issues, some floors have interdisciplinary meetings. So if you have a chance to attend to those, to voice your concerns, you can. My floor, which is neuro ICU, we do have interdisciplinary meetings where we talk about issues and find ways to resolve them. Also, I've had some nurses shadow pharmacists in the pharmacy. It's not always possible, but if it's something you like to do, talk to your pharmacist to see if we can get you in. I think sometimes it's hard for nurses to understand how the pharmacy works. But the pharmacy actually works in a way like an assembly line, Several steps has to be done before a medication is delivered to the nurses. And sometimes that takes a little bit of a time. If you can understand and see those processes, maybe it will make it a lot more understanding when there are delay in getting meds to you. And then talk to your pharmacist before you launch a complaint. If there's an issue, don't go to your director when there's a pharmacist over there, because it makes us look like we don't know what we're doing or like we're not helpful. Come to me first or come to the pharmacist first and ask for help. And then just in general, if there's just other issues that you can get to, email the pharmacy director or talk to your director to get to the pharmacy director so that we can find a way to solve your problems for you.
How the lab scientist role affects nursing and how we can all work together. Diagnostic tests that the laboratory scientists perform help nurses assess the patient's status. A lot of times, if there is an error or we're seeing a discrepancy in results, we will call the nurse and ask if it correlates with the current patient's status. Sometimes it doesn't, and sometimes it does. And that helps us ensure that accurate results are going out, because ultimately our goal is to take care of the patient. 70% of all medical decisions are based on the lab results that laboratory scientists do send out on reports. So in that case, our goal is to always strive for accurate results. Pre-analytical errors account for 75% of all lab errors. The overall lab error rate is around less than 0.6%, but when 75% accounts for pre-analytical error, and that can be specimen ID, specimen collection, and are we getting the proper tubes that we need in order to do that test? Is it a test that needs to be on ice? Did we receive it on ice? Can that specimen be tubed to the lab? Does it have to be walked to the lab? There are reasons that those requirements are in there, and it's to send out accurate results. Again, our overall goal is to always send out accurate results because patients are treated based off of our results. The very first line of preventing errors is patient identification. A lot of nurses will call us and ask for room 354. Those of us in the lab and the scientists, we have no clue who room 354 is. We work off of names and their medical record number, and that's to ensure that we are identifying the patient properly. Because once those tubes of blood land in the lab, then all we have is a tube of blood. Everybody's blood looks the same. We all bleed red. The only thing that we can probably tell is if it's a lower H&H or a higher H&H. Otherwise, everybody's looks the same, and the only way we can identify those tubes positively is by proper patient identification. That requires the label being on the tube so that we do know that that tube belongs to that patient. In properly labeling the tube, please place the label straight. The barcode needs to be vertically instead of diagonally or horizontally, because all of the lab is automated. All of our barcode readers on the analyzers are set up to read vertically. And so while it doesn't seem like a lot to place that label vertically, it means a lot to us, because if we have to relabel every sample that comes into the lab, and it's thousands of samples a day, that is extremely time consuming. And so that slows down the process if we end up having to relabel the tube. Or if the specimen comes down and it's not labeled, but the label's in the bag, that's still an unlabeled specimen because we don't have positive identification for that specimen. The label always needs to be on the tube. Just recently, we've had a NICU baby specimen come down that was not labeled. Those are the ones that break our hearts, because we know that those patients are critical and that it is hard to get blood from those patients. We don't like having to call for recollects because it wasn't labeled. Please take the extra time to label the tube. That is probably one of the most critical steps in collecting specimens so that the lab can do our processes and our jobs correctly is proper specimen identification. Also, if you draw a lavender top and a green top and a red top, and you place the lavender top on the green or the red top, those tubes are processed differently than a lavender top. The red and green top will get spun down, but if it has, whereas the lavender top will not get centrifuged, and if it does get centrifuged, then we have to call for a recollect. Every tube has a reason for why it is the tube of choice for that test. And lab scientists are trained and educated on the theory behind each test, and that is why we do require certain specimen requirements. Each tube has a different anticoagulant, or maybe doesn't even have an anticoagulant in it, and that will determine the test and the test results that are coming from that specimen. Chemistry tubes are different from your hematology tubes, which is your CBC, your H&H, as well as your blood bank and even microbiology. When microbiology is calling for blood cultures, that is one of their most common errors that they see, is the source is not labeled, as well as date, time, and initials. A lot of that has to do with our regulating agencies as well, which we have to follow, as well as for insurance purposes. If it's the same source, then we can't bill for it, and that's money lost for UMC. One common misunderstanding of the lab's role and nursing, between nursing, is just an overall understanding of lab processes as well as each individual's role in the lab. We do have phlebotomists that are on the front line that you'll see more frequently than you will see anyone else. Then we have lab processors, and they handle every specimen that comes into the lab so that it gets distributed to the correct departments. And then you have the lab scientists that are monitoring the analyzers, making sure they're all working so that we can send out accurate results, as well as we're the ones reporting the test results, or we're the ones calling you with criticals. A common misunderstanding is that because one test might take 2 minutes to run and another test might take an hour. Each test has its own individual time to complete, and we can't always guarantee that it will get out in that specific amount of time. We have to make sure the analyzers are working first, and that we do spend a lot of time making sure that they are working. And so just calling because you just sent that specimen to the lab doesn't mean we can get those results out in 30 seconds. It does take time. We do need to load it onto our automated system, which then sends it to each analyzer, and then we can do the testing. And again, each test has its own time frame in order to be able to obtain the results. A common one that you will call about are glucoses, and that one specifically takes about 10 to 12 minutes to run. If it's high, then we have to dilute it, and it will take even longer. So please understand, we understand that your patients are critical and we want to help you, but we also are limited by the time that it takes for each test to run. One way to improve the roles between nursing and laboratory is having open communication. We understand that you're going to call. Please call us if you have a question. It's always better to get the answer up front if you're unsure what specimen to collect than it is to just draw something randomly and then call us and say, hey, this is what I got. We can't always fix those because each test does have its own requirement. And just have an open mind and remember that you may be having a frustrating day. We also may be having a frustrating day because there are several days that our analyzers are down, and those are frustrating because we're trying to find workarounds so that we can keep results going out in a timely fashion. We understand that patient care is dependent upon our results and that they are getting out in a timely manner, and we're trying to do that as fast and as best as we can. I appreciate your time. Thank you for listening. And remember, you can always call the lab and ask us questions first. We would love to help you and get the results accurate the first time.